So Pam, as we're speaking about clinical trials, and we know the various different drugs that are active in pancreatic neuroendocrine tumors, thinking about combinations and perhaps first combinations of somatostatin analogs and other drugs, is that an area that we need to explore further?
Yeah, I think that's a great question. We have a number of agents now available to us. Should we be using them in combination or in sequence? I think that some clinical trials are starting to look at some combinations, but I think that many of us have talked about this before in patients who live for a long time, for whom we may not want additive side effects. Sequential therapies may make the most sense right now. The two studies that were presented at today's ASCO meeting, one was SWOG 0518, looked at the use in carcinoids of both arms had octreotide in them, and then interferon versus Bev. And then the CLGB study in pancreatic NETs also both had octreotide in them, and then was everolimus plus or minus Bev. And so those were combination studies. I mean, you presented your CLGB study, and that was the positive study, but had some additive toxicity.
Absolutely. I mean, my sense in thinking about the combinations is that really for all of these drugs, we pretty much know that somatostatin analogs can be safely administered.
Right.
That's not a huge question. The tougher question is looking at combinations of either chemotherapy and targeted agents, or as in the study that we were just discussing, studies of combinations of targeted agents, mTOR inhibitors and VEGF inhibitors. And this particular randomized study compared treatment with everolimus to everolimus plus bevacizumab, showed a higher response rate in the combination arm and also a higher progression-free survival. So it does suggest that combinations are more active. There are some caveats. Diane, you discussed the study today, and why don't I turn to you to tell us what some of those caveats are.
Right, so like you said, I mean, it was a paradigm shift to see two targeted agents having a response rate of 31%. I mean, that's really exciting that like the science works. I think that with everolimus we had some improvement of PFS, but that response rate was quite remarkable. But it certainly didn't come as a free lunch. 81% of the patients had grade 3 to 4 toxicities, and things that you would expect, like hypertension, unfortunately an MI and cardiac arrest in 3% of those patients, but things that you may not expect. So again, it was smaller numbers because it was a randomized phase 2, so I definitely think there needs to be caution in how we interpret the data, given that it was a phase 2 and not a phase 3. But 11 times higher rate of diarrhea, again, small rates, but still higher, and something that you wouldn't necessarily expect, in addition to electrolyte disturbances and other things. So I think that a phase 2 study can show us efficacy and safety, but I think there was caution to sort of where do we go with this, that the combination therapy clearly had a better response and better progression-free survival, which was really exciting, but at what cost are we willing to take that? And I think certainly further trials need to be considered before making that claim.
There was another study presented also at ASCO, another large randomized study, a phase 3 study, that looked in carcinoid patients and compared interferon versus bevacizumab with no difference seen. Does this mean that the drugs don't work? Does it mean they both work? How do we interpret that?
That's the billion-dollar question. So the interferon alpha was the comparator arm, and in the United States that's rarely used, quite frankly because of the toxicity. And so the true efficacy of that drug is really unknown. Again, this is a patient population that can live for years. So when you have significant grade 3 fatigue, most of us as clinicians aren't willing to do that. But nevertheless, the study used interferon as a comparator arm, and the PFS was the same. So the study did not meet its endpoint, and it was negative. But if you look carefully at the data, the PFS was 15.5 months in one arm and 16.6 months in the bevacizumab arm. Those are great PFS. But again, in our patient population, was it biology and ineffective drugs?
Remember, the clarinet study had a placebo.
Exactly. Placebo, 18 months. We don't want to do the cross-trial comparison, but I don't know if we have two ineffective drugs with good patient population, or if we actually have two effective drugs that actually both worked. And then the study just proved them both to be negative, basically, because the study didn't meet its primary endpoint. And it's very unsettling, and I think it really, for all of us, was a learning experience of how do we better design these trials, because the statistics can be so tricky, and really understanding. And then, if you're going to have that as a comparator arm, you have to understand, is it efficacious, and if so, about how well, or or what are we willing to consider in terms of the toxicities?
Some of the drugs that have been bandied about and tested in very early stages include a serotonin inhibitor called telotrestat. Pam, can you tell us a little bit about that particular drug and what's known?
So I think, telotrestat is an inhibitor of TPH, which is the rate-limiting enzyme in the synthesis of serotonin, and we'd talked earlier that serotonin is really the primary hormone responsible for carcinoid syndrome. So I think to have, and this is an oral agent, so to have another option other than SSAs for hormone control, I think is exciting. It's in phase 3 trials right now, so I think we won't know probably for another year whether this is an effective agent, but I think it's really exciting to have another option, potentially.
And what about immune therapy? We hear about this in the news almost every day. Is it going to have a role in neuroendocrine tumors?
Don't we want part of that pie too?
We'd love a part of that pie.
Yeah, I think, well, if we think of interferon being the original immunotherapy in neuroendocrine tumors, maybe there's some role, but I think that, we've all seen the figure of tumors by number of mutations present, and I think that neuroendocrine tumors are not classically considered an immune-sensitive tumor because of the low number of mutations. But so for single-agent immunotherapies, perhaps that may not make sense scientifically, but I think using combination immunotherapies may help overcome that. So I think there are some small investigational studies starting. So we will be conducting a study using a combination of intratumoral ipilimumab and an anti-PD-L1 inhibitor in a very small 20-patient study, exploratory. I think there are some other studies or some other institutions that are starting to look at immune therapies, but I think it's an exciting field that we should try to apply to neuroendocrine tumors.
Absolutely. Another area that's been relatively unstudied, I want to turn to Diane. PROMID looked at somatostatin analogs in small bowel carcinoid, clarinet, and a broad range of gastroenteropancreatic neuroendocrine tumors. We always ignore lung and thymic neuroendocrine
those poor
tumors.
lung and thymus.
So what are we going to be looking at there?
So we're going to do a Me Too study for those poor lung and thymus patients. And I do think that we should test the role of somatostatin analog therapies. And so we have developed a concept with Ipsen to try to test the benefit of lanreotide versus placebo in a randomized phase 2 in patients with lung and thymus. I think it's really important that many times these patients, particularly the atypical carcinoids, are often treated like small cell lung cancer without really any great data to do that. So we should really focus on them and try to consider other therapies. There was a press release with the RADIANT-4 last week that included lung. So we don't know those results yet, but certainly that is something that we eagerly wait to see if everolimus is beneficial in lung carcinoids as well.
Great, thank you.
I have a question on that. Are you using temozolomide and capecitabine for lung nodes?
That's a great question. So my guess, because we truly don't have, we have some data in a phase 2 that temozolomide was active, but I tend to use temozolomide-based therapies in the so-called foregut tumors, lung, duodenal, pancreatic. I do not and never use temozolomide-based therapies in midgut. I don't believe that data. So I don't know how you all feel, but I do think that there's a role for Temodar in lung.
I think it needs to be studied, but I do also anecdotally.
It's sort of studied already, though, right?
Well,
Matt, you
we
did
have a
those
small
studies
series
in
of
Small
about 100
studies.
patients.
Oh, for lung.
Yeah,
For lung.
Yeah, for lung.
Very
I'm sorry.
promising.
For lung
Yeah, for
specifically,
lung.
I think we're now becoming we're splitting into
Right.
smaller groups, but I think that probably needs to be done. And
Yeah.
studying lung specifically, I think, is a great idea.
Absolutely.